All right. Good afternoon, everybody. It is Tuesday, December 1st. It is beautiful outside. What a nice Florida day. Man, it's cool outside. I'm even wearing long sleeves. It's really, really nice. Problem is it's cold in the school for a change, so it actually feels good. Just want you guys to know that, Bridget, if you have any questions today, please feel free to stop me from talking and ask the question. We're going to be going deeper into the muscles over the rest of this week. So what I'm going to be doing this week is going over the muscles, the origin, insertion, actions, and innervations of these muscles, and what we are going to need you guys to know. Okay. So once you get through with the bones, really start working on the muscles. Get the practical muscles down. If you get those down, you're getting about between 40 and 50 muscles done with. All right. But please understand, it's not just the identification that is important. It's the understanding of where this muscle is located. What is its origin? What is its insertion? Because this information is going to tell you and guide you in what a muscle does. All of these muscles have specific actions. And we as physical therapist assistants need to understand those actions, because we're going to be working on these muscles and we're going to try to strengthen them and stretch them so they become functional. So we have to really understand everything about these muscles. So again, we're not going through every muscle in the body. I'm going to tell you what I need you guys to know. All right. And what is going to benefit you to know. There's certain sets of muscles that is on the upcoming PowerPoint that I'm going to tell you don't worry about. All right. Don't worry about certain muscles. There's some facial muscles that I'm not going to want you to worry about. There's hyoid muscles that I don't want you to worry about because we don't work with them as physical therapist assistants. So I am going to tell you what you need to know. All right. I'm going to be very, very specific. And there's certain muscles that I'm not even going to want you to know the origin insertion, but I'm going to need you to know the actions because they're so important also. So that's what the next couple of days are about, is muscle, 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 and everything about it. All right. So I'm going to pull up the screen. Today I will send when I send the video, I will also send this PowerPoint with it. All right. The PowerPoint is all the muscles that you guys are going to need to know. All right. Let me go to the full screen here. Bridget, do you see that?
Yes.
Anatomy review. All right. Fantastic. All right. So let's begin the festivities. All right. So this is a picture of the muscular system. Again, like I spoke about yesterday, when we're looking at these muscles, you need to understand where they are and what other muscles are located in proximity to these muscles. Because a muscle on the anterior side of the body is going to do certain things, and most muscles on the posterior side are going to do certain things. So when we're looking at, let's say, flexion of the shoulder, there aren't many muscles in the posterior portion of the body that performs shoulder flexion. Like I said yesterday, there are 4 main muscles that perform shoulder flexion: the anterior deltoid, the biceps brachii, the coracobrachialis, and the pectoralis major. Those are all muscles on the anterior side. So There are some of those tricky muscles also, you know. So you got, let's say, the back muscle like latissimus dorsi. Latissimus dorsi is on the back. If we look at the next screen, you know, so we have latissimus right in this area. Give me 1 second. We have latissimus, this big muscle right here. All right. But what's tricky about the latissimus is that latissimus inserts onto the humerus. It inserts on the humerus. So this large back muscle actually has an action, has multiple actions at the humerus, like extension of the shoulder. So it's really important to understand where these muscles are located, what muscles are close by, and that will really help you get a really better and clearer understanding of these muscles. Boy, things don't want to advance when I want them to advance. Come on, silly. A different way. Okay, we got that. Go backwards, frontwards. There we go. All right. So the first set of muscles that I want to talk to you about are the muscles of chewing. Now, we as physical therapist assistants, we do treat TMJ problems, temporomandibular joint problems, but it's not one of the, let's say, how can I put this? More advanced, this is a more advanced topic that physical therapist assistants performs, and it takes more knowledge than what we offer you in the physical therapy assistant program. But what I'm going to need you guys to know is you're going to need to know one of the muscles, all right? But I'm going to need you to understand what these muscles do, what the actions of these muscles are. Now, there are 4 important muscles to chewing, all right? I'm not going to ask you that you know every single muscle. But what I am going to want you to know, first of all, is how the mouth opens and closes and how the mouth moves to perform the chewing movement. So some of the words that you will see, when we depress our mandible, and what I mean by depress is bring your mandible down like this. When we depress the mandible, we are opening the mouth. When we depress the mandible, we are opening the mouth. So that's when the mandible goes down or goes inferiorly. In order to close the mouth, we elevate the mandible. So opening, depression, elevating, closing. In order to chew, we have 3 other movements. We have something known as protraction of the mandible. Protraction is where we bring the mandible forward. So if you were to just move your chin forward like that, I know it looks weird, but forward movement of the mandible is protraction, and that's where the incisors actually cut the food. And retraction is the returning of the mandible, and that's where the rear teeth meet. So protraction, the moving forward of the mandible, retraction, the moving back of the mandible. So pro and re. You're going to hear those words again when we talk about the shoulders. Remember, we spoke about that in Zoom meeting number 3. In our movement, we talked about protraction of the shoulder, and retraction of the shoulder. So again, protraction of the shoulder is forward movement. So is protraction of the mandible. Retraction is the returning of the mandible. And finally, the last movement is lateral and medial excursion. And that's where we actually grind our food. So if you were to move your teeth medial and laterally, kind of like this, from side to side, that is medial and lateral excursion. And if you had a piece of meat in your mouth and you did that, you would actually be grinding your food. So I need you to understand what the movements of the jaw is. Again, depression opens the mouth, elevation closes the mouth. Protraction moves the mandible forward, retraction moves the mandible back, and lateral and medial excursion is the side-to-side movement of the mouth. Now, there are 4 muscles for chewing. Like I said, I'm only going to need you to know one of them, and when we get to it, I will talk about it. But you'll notice on the bottom here, this bottom line is underlined. These 4 muscles are innervated by cranial nerve number 5. Remember, there's 12 cranial nerves, all right, that are from the brain, and they make up most of the face and the shoulders, all right, where, you know, the nerve innervations for breathing and for eyesight and for opening and closing your mouth comes from these cranial nerves. So I want you to know that the muscles of chewing, all 4 of them are innervated by the trigeminal nerve, which is cranial nerve number 5. Okay, we will talk about the cranial nerves a little bit more at the end of intro, where we'll go over all 12 of them. But for the muscles of chewing, you need to know that it is cranial nerve number 5, which is the trigeminal nerve. So let's go through these muscles. Like I said, there are 4 muscles to chewing, and you're only going to need 1. But I want you to know these other things real quick. So here's temporalis. Temporalis is a very important muscle for closing the mouth. What I also want you guys to notice is, notice the name of the muscle. Whenever there is a star next to it, that is a muscle that you're going to need to know. So temporalis does not have a star. It will not be on any of my tests. And again, most likely not on a national exam. Okay? So temporalis is a muscle that closes the mouth. The next muscle is the masseter. Masseter is another muscle that closes the mouth. Okay, so temporalis and masseter, both muscles that close the mouth. The third muscle is known as the medial pterygoid muscle. All right, yeah, I know it looks weird. It's pronounced pterygoid. Okay, this is the third muscle that closes the mouth. Okay, the third muscle that closes the mouth. And again, these first 3 muscles you're not going to need to know, but know that the next muscle is one that you're going to need to know, and I'm going to tell you what you need to know on it. But it's a muscle, the next muscle is a muscle that actually opens the mouth. Okay? So there's really only one muscle that really opens the mouth. And that muscle is known as the lateral pterygoid muscle. So those other 3 closes the mouth, but the lateral pterygoid opens the mouth. Okay, so that is something I definitely want you to know. Okay, that the lateral pterygoid opens the mouth. Okay, the other thing I need you to know about this is where this muscle inserts into. Now, we're going to talk about this muscle more in depth in kinesiology because we have a section that talks about the temporomandibular joint. But what I need you to know is that the lateral pterygoid inserts into the articular disc of the temporomandibular joint. Now, this is an important structure. And it's interesting. If you guys were to take your fingers and put your fingers on that cartilage part of your ear and press down a little bit and open and close your mouth, you will actually feel your own temporomandibular joint. That's the temporomandibular joint moving. All right. And this joint is used all day long. Think about it. I'm over here opening and closing my mouth, talking, and then I stuff food in it. And so that TMJ is moving all the time. It's a joint that is going literally almost 24 hours a day. So the lateral pterygoid opens the mouth in comparison to those other three. All right. But more importantly, the lateral pterygoid inserts onto the articular disc, and that articular disc is the structure that moves and allows the temporomandibular joint to move in a free way. If you know somebody or even yourself has ever had a temporomandibular joint problem or TMJ, you probably felt this clicking, or maybe even, unfortunately, where you opened your mouth and it literally just froze there, where you can't close it. Well, it's because of this articular disc. When that articular disc is blocked, it's going to keep your mouth from opening and closing correctly. So the lateral pterygoid is the muscle of chewing that we are going to need you guys to know. And again, I'm not going to ask you the origin of this muscle. All right, I'm not going to ask you all of its actions. What I want you to know is that its insertion is on the articular disc, and the lateral pterygoid opens the mouth. It depresses the mouth. Remember, depression of the mandible is the opening of the mouth. These muscles, these next few muscles, I do not want you to know. So the hyoid muscles, these are muscles that connect to the hyoid bone, which is that floating bone in the neck. Again, as physical therapist assistants, we truly don't work on these muscles, so we will not ask you about them. And there's a 99.9% chance that they will not ask you that either, because the ones that make up the test know what muscles we use. So hyoid, not one of them. Again, the infrahyoid, don't need to know. So let's talk about some muscles on the neck. So the muscles that act on the neck originate on the vertebral column. So some of them come from the spinous processes. Some of them come from the transverse process. Some of the neck muscles come from the thoracic cage, the sternum, okay? And some attach to the pectoral girdle or the shoulder. All of them, though, because they act on the neck, will insert on the cranial bones. So they have to insert on the cranial bones to move the head, to move the neck. So let's kind of go back to the third video that we showed, where I kind of went over the movements. So the movements of the neck, when you tip your head forward like this, it is known as flexion. When you bring your chin to your chest, that is cervical flexion. When you bring your head back like you're looking at the ceiling, that is cervical extension. When you tip your head to one side, and what I mean by that, if you were to bring your ear to your shoulder like this, that is known as lateral flexion. So you can laterally flex to the right and you can laterally flex to the left. And rotation is where we turn our head. Basically, it's no. So rotating your head to the right and rotating your head to the left. So these are the motions of the neck. Now, remember in that third video, we also went over some terminology where we spoke about directions. Some of these neck muscles are very, very confusing and kind of hard to understand sometimes. So you have to understand which muscle is working and in which direction they are working. So let's go over the terminology again. A movement that is contralateral is movement of the head towards the opposite side. All right? A contralateral movement is moving to the opposite side. This is what it means. If I'm looking at the left side, a muscle on my left side, the movement will go to the opposite side or the right. When we talk about the sternocleidomastoid and the scalenes, they have movements to the contralateral side. And we'll talk about that because it's really, really important. So contralateral means movement to the opposite side. Ipsilateral means movement to the same side. Look at the S in ipsilateral. Ipsilateral with this S, give me a second here. Let me kind of go back. My apologies. This is really a good reminder. Contralateral, there's no S. Ipsilateral, there is an S. Remember, ipsilateral is to the S side. It's to the same side. So if I'm looking at a muscle on my left side, an ipsilateral movement will go to the left side. Okay? So very important. Contralateral, movement to the opposite side. Ipsilateral, there's an S in it. It moves to the same side. Okay? So hopefully that will help you in the recall of those two definitions. All right? Ipsilateral is telling you that it's the same side, and that S helps there. So the main neck flexors are the sternocleidomastoid and the scalenes. The main neck extensors are the upper trapezius and the splenius muscles. Now, a couple of these muscles you are going to need to know, and a couple of them I just want you to have an understanding of what they do. Okay, so let's go through. Let's start with the sternocleidomastoid. Let me get rid of that. So the sternocleidomastoid, let me get my little pen here, is this muscle right here that looks like a big, thick strap. All right? And you can feel it in your own neck. All right? Sternocleidomastoid. You need to know everything about this muscle. You need to know the origin, insertion, the actions, and the innervation. Okay? So, what's great about the sternocleidomastoid is that it is already telling you its origin and its insertion. So, its origin is the manubrium of sternum, hence sterno, and the medial third of the clavicle, hence cleido. Sternocleido is sternum and clavicle. The insertion is into the mastoid process, hence sternocleidomastoid. Not every muscle is that easy, but this is a good one, okay? So the origin is the sternum, the top, the manubrium portion, and the clavicle, and the mastoid process is its insertion. Now, there is also a piece of this muscle that is on the superior nuchal line, which is on the posterior portion of the head. It's not an important portion that you are truly going to need to know. What I do need you to know is that the origin is the sternum and the clavicle, and the insertion is on the mastoid process. This muscle is innervated by cranial nerve number 11. Cranial nerve 11 is the accessory nerve. Now, again, like I spoke about earlier, it's important to understand the muscles surrounding it. All right. So this muscle right here, and I'm just going to put a line through it. It's coming from the back of the head, and it's actually attaching to the clavicle. Well, that muscle is the upper trapezius muscle. The trapezius also is innervated by cranial nerve number 11, the accessory nerve. So knowing innervations is hard enough, but if you can kind of combine things, it'll be easier to remember. So again, sternocleidomastoid and the trapezius muscle is both innervated by cranial nerve number 11, the accessory nerve. Now, sternocleidomastoid has multiple actions. First of all, you have a sternocleidomastoid on the left side and on the right side. When they work together, that is known as bilaterally. They're working together on the right and left-hand side. What they do together is that they flex the head and the neck. So bilaterally, it brings the chin to the chest. It has two very important unilateral movements, and they're both very tricky, unfortunately. So when only one sternocleidomastoid works, one way it works is it laterally flexes the head. It laterally flexes the head to the same side, to the ipsilateral side, which means if only my left sternocleidomastoid is working, it performs lateral flexion to the left. And guys, what I want you to do is feel your sternocleidomastoid in your neck and bring your left ear to your left shoulder, and you will feel that muscle work. You will feel it work. The other action that it does is it has a contralateral movement. It rotates the head to the opposite side. So again, if I'm feeling my left sternocleidomastoid, it has the ability to rotate to the right side. So when both sternocleidomastoids work, it flexes the neck. It laterally flexes to the ipsilateral side, and it rotates to the contralateral side. And I want you to try something. So again, feel your left sternocleidomastoid. And what I want you to do is rotate your head to the left. You will not feel that muscle contract, right? Because again, the left sternocleidomastoid does rotation to the right. It laterally flexes to the same side. So again, the left sternocleidomastoid laterally flexes the head to the same side. So the left will laterally flex to the left, and the left sternocleidomastoid can rotate the head to the right. Okay? Yes, confusing. Unfortunately, you gotta know it. And one of the reasons you have to know it is because of one of the disease processes that the sternocleidomastoid is part of. If you've ever heard of torticollis, torticollis is a childhood disease. And what happens is that babies actually, the sternocleidomastoid becomes so tight that it actually stays in all the motions that the sternocleidomastoid does. So if the left sternocleidomastoid has torticollis and is tight, it will actually flex the neck, laterally flex to the same side, and rotate to the opposite side. So you will see children that actually look like that with their head in this very uncomfortable looking position. That is what torticollis is. Torticollis is tightness of the sternocleidomastoid in all the directions that the SCM performs. So the sternocleidomastoid is a very important muscle because we educate the parents of these children to stretch them. And stretching is just the opposite of the problem. So we actually teach them to extend the head, all right, rotate to the opposite side, and laterally flex to the opposite side. And that's how we get them to stretch the sternocleidomastoid. Now, when you get your flashcards, one of the actions that some of these flashcards has is the contribution to neck extension. I don't want you to worry about sternocleidomastoid as a neck extender. It is not a primary mover of that movement. There are other muscles that have that movement as a primary movement. So the movements that I am telling you to know, the flexion of the head bilaterally, the lateral rotation to the same side, and the lateral flexion to the same side, and the rotation to the opposite side are the movements that you need to know. So again, take a look at this picture. It's going to show you a lot of muscles that are in this area here. A lot of small muscles. Sternocleidomastoid, though, is very, very strong muscle. Okay, so that muscle is starred. You definitely need to know it. The scalenes also has a star on it, but you don't need to know everything about the scalenes. What I need you to know about the scalenes is that scalenes are made up of 3 muscles, and I'm circling them right now. There's an anterior, there's a middle, and a posterior. All right? There are these 3 muscles, and they attach to the first 2 ribs. Okay? So I want you to know that the scalenes are 3 muscles and that they attach to the first 2 ribs. What I also want you to know is that they perform the same actions in the same way that sternocleidomastoid does. Scalenes bilaterally flexes the head and neck, laterally flexes the head and neck to the same side, and rotates the head to the opposite side. So scalenes and SCM have the same actions. But because the scalenes attaches to the ribs, has an insertion point on the first 2 ribs, it has an important aspect for breathing. When we breathe, normally we have this nice, easy in and out, inhalation and exhalation of our breath. But people that have COPD, which is known as chronic obstructive pulmonary disease, sometimes the muscles that perform the nice, easy breathing are hypertrophied. They're very, very weak. So what happens is when people with COPD breathe, they actually breathe kind of with their neck. So it kind of looks like this. They bring their shoulders and their neck up. So the scalenes are actually used to help patients that are having trouble breathing. This is known as a compensation. All right. It's not normal for us to use our neck muscles for breathing. But when we have muscles that are not working efficiently, when we have certain breathing muscles like the diaphragm or the internal and external intercostal muscles, when those muscles aren't working well, sometimes we have to use other muscles to compensate. And because the scalenes attach to the ribs, it lifts the ribs up and helps compensate in breathing. So what I need you to know about the scalenes is that they insert onto the first 2 ribs. Scalenes has the same actions as the sternocleidomastoid, and the scalenes works as a compensation for breathing for people who have COPD. All right, if they're having trouble breathing, they use the scalenes to compensate for their breathing. So that's the information that I'm going to need you to know for the scalenes. Now, I have a star next to Splenius, capitis, and cervicis. Please notice on the bottom where it says action, it is bolded out. This is what I need you to know about Splenius, capitis, and cervicis. This is the only information I need you to know. I need you to know that this muscle extends the head and neck. All right, remember, scalenes and sternocleidomastoid flex when they work together. Well, Splenius, capitis, and cervicis are neck extensors, are head extensors. Okay? That's the important part of this muscle that you need to know. Okay? When this muscle also helps with rotation and lateral flexion. And when you're thinking about splenius and those two movements, those movements occur ipsilaterally. They both occur to the same side. But again, most important, splenius capitis and splenius cervicis assists the trapezius in extension of the head and the neck. That is what is important about this muscle. The ligamentum nuchae, like I said yesterday, is a ligament that extends from the occiput down into the C7 area. And it's just a deep ligament that attaches there. And all this ligament does is it adds increased surface area. It allows for some muscles to attach to this deep fiber so it has a strong attachment. So it adds for surface area. So you will hear that, you know, like sternocleidomastoid is one of those muscles that actually attaches to that ligamentum nuchae. Okay? So it adds surface area. It's a ligament. Thankfully, it's in the name. But what it also does is it limits head flexion. Think about it. If we didn't have something to keep our head from flexing, it would literally kind of fall down and fall down forward. So this very strong ligament on the posterior half, think about it, keeps and limits flexion of the neck. So again, the important part of this structure is what's happening on the bottom of this PowerPoint. It functions to limit flexion of the neck and is a muscle insertion. That is what you're going to need to know about this because you're going to hear it. All right. Again, it's a very strong ligament. It's found basically from the occiput to the C7 area. So ligamentum nuchae. So the muscles of the trunk, we have trunk muscles on the anterior portion, and we have trunk muscles on the posterior portion. These muscles have there are three reasons for these muscles. They are muscles of respiration. They help move the vertebral column. And they are support structures for the abdominal wall and the pelvic floor. So these trunk muscles are very, very strong, very thick. Some of them are in between the ribs, so they're even kind of small sometimes. But they have very important functions in respiration, helping us breathe, helping us move our back, and it supports, especially at the pelvic area, it supports the abdominal wall and the pelvic floor. So again, it's important to understand what muscles are superficial and what muscles are deep. So again, it's important to understand that superficial muscles are muscles you can actually touch. And the word we use for touch is palpate. So we can palpate the sternocleidomastoid. We can palpate the pectoralis major in our chest. If we go to the forearm, we can palpate the biceps. It's right there. Those are the superficial muscles, the muscles that we can touch. But then we need to understand the muscles that are deeper. So we have pectoralis minor, which is deep to pec major. We have the serratus anterior, which comes off of the ribs and attaches to the medial border of the scapula. And we have subclavius muscle, which is actually underneath the clavicle itself. Again, and that's another muscle that is telling you where it is. It's not a muscle that you're going to need to know, but again, the name of the muscle is telling you. Sub means below, clavius means clavicle. Subclavius, below the clavicle. So again, that's you've got to understand what muscles are superficial and what muscles are deep. Okay? Because as we go along in the program, when we get to certain classes like modalities, we're going to need to treat some of these deeper muscles. So we need to know which ones they are. So again, we have some muscles that are muscles of respiration. All right. Breathing requires the use of these muscles. So some of the muscles that help with breathing, the most important is the diaphragm. But we have the internal and external intercostals. Again, the intercostals are muscles between the ribs. Now, some of the terminology that you need to know when we're talking about breathing is terminology for taking in air and the releasing of air. So inspiration is the intake of air when you breathe in. When you take a deep breath, you're intaking the air, and that word is inspiration, taking in air. When you are releasing the air, you are expelling it, hence it's expiration. So inspiration is the taking in of oxygen, expiration is the expelling of air. Smelling the flowers is inspiration, blowing out the candles is expiration. And believe it or not, that's a way we actually teach our patients not to hold their breath, to work on their breathing, because muscles need oxygen. When a patient holds their breath, they're not getting the oxygen to the muscles that they need. Think of somebody that you have seen at the gym. All right, those big muscle building guys, they lift the weight and they hold their breath. They hold it and hold it and hold it. Well, that's not good. The muscle needs that oxygen. So we tell our patients to breathe. So again, smelling the flowers, inspiration, blowing out the candles, expiration. Now we have these other muscles that contribute to breathing. We talked about the scalenes, which is more of a muscle used when a patient has breathing problems. But some of the other muscles that you might see is pec major and serratus anterior, the latissimus dorsi, a lot of the abdominal muscles, internal and external obliques, and the transverse abdominis are also muscles that help with breathing. Okay, so let's go over some of these muscles. Excuse me. First is the diaphragm. The diaphragm is the primary muscle of inspiration. When we take in air and when we take it in easily and normally, it is the diaphragm that does the work. This is a muscle you're going to need to know. All right. This muscle has an attachment point on the xiphoid process. Has its origin on the xiphoid process and the lumbar area, and its insertion is also on the lumbar area. Okay, so the diaphragm comes off of the xiphoid process. Remember, that xiphoid process was that small bone at the end of the sternum. Remember, the sternum has those three parts: the manubrium, the body, and the xiphoid process. The diaphragm comes off of that xiphoid process. Again, the main action of the diaphragm is inspiration. And I also need you to know the nerve, the innervation of this muscle is the phrenic nerve. Now, when you're going to see sometimes next to these nerves, these numbers, C3 through C5, this is the cervical, this is the area that this nerve comes out of. I don't need you to know that information now. In later classes, you'll need to know it. One less thing that you have to worry about. Understanding and knowing the innervation of these muscles is daunting enough. Okay, so don't worry about the C3 through C5 or T4, T6, and things like that. What I need you to know is the diaphragm is the primary muscle of inspiration. Its innervation is the phrenic nerve. Its origin is the xiphoid process, and its its insertion is the lumbar vertebra itself. So the diaphragm, the primary muscle of inspiration, the primary muscle for breathing. The internal and external intercostals, these are muscles between the ribs. And remember, when we're breathing, our ribs expand and contract. Well, it's the internal and external intercostals that perform that action. What I need you to know about the internal and external intercostals is the actions. I don't need you to know the origin, the insertion, or the innervation. I'm not worried about that. All right? But I need you to know what these muscles do. So you'll notice under actions, I have them colored. Those are the important things that I need you to know. The external intercostals, they help with inhalation. They expand the thorax. Remember, when we take in a breath, we're taking in a lot of air. The area that we need has to expand. So our ribs expand, allowing for as much air as we can take in. It's the external intercostals that expands the thorax and allows for maximum inhalation. The internal intercostals assist with exhalation. Basically, it draws the ribs inwards, pushing the air out. Remember, exhalation is air going out, blowing out the candles. So the external intercostals is for inhalation. The internal intercostals are for exhalation. Now, I want you to know something. I want you to notice something. All right? External inhalation, internal exhalation. EI, IE. All right? So if you get a little confused, you're like, oh man, which way is it? External intercostals. So external is the I, and that's inhalation. Internal is the E, it's exhalation. That's really a nice way to kind of remember it. All right. Again, I try to give you little things to kind of help you out because these are things that literally helped me pass my test. Okay. And I did pass my test. So these are the little things that I tried to remember because there is an awful lot of information that you need to know. So again, external intercostals are for inhalation. Internal intercostals are for exhalation. An important piece of information, and we'll talk about this in kinesiology, is that the diaphragm and the external intercostals work together, all right, to perform something for tidal volume. And we'll get to that when we get to kinesiology, all right? Not something you need to worry about now. What I need you to know about these muscles is that they help with breathing. They're located between the ribs. The external intercostals assist with inhalation. The internal intercostals assist with exhalation. EI, IE. Here's a muscle you guys know very well. And by the way, some information for kinesiology. You probably think this is your core muscle. Guess what? It's not. The rectus abdominis is not a core muscle. I will teach you about that in kinesiology. So what I need you to know about rectus abdominis, what I need you to know about the six-pack muscle, all right? I need you to know its origin. Its origin is distal. It's low. Its origin is actually down here, down in this area. The origin is the pubic crest and the pubic symphysis. Okay, so this muscle actually starts distally. All right, so here's its origin. Its insertion point is the xiphoid process right here. So here's the sternum, and here's the lowest part of the sternum. So this is the insertion. And this is important because, like I spoke about yesterday, when we're talking about muscle contraction, muscles contract in a certain way. And the way it contracts is that the insertion comes closer to the origin. So let's think of it this way. We'll talk about the biceps. I don't know if it's today or tomorrow, but when you flex your elbow, the insertion point is the radial tuberosity on the radius bone, and its origin is the supraglenoid tubercle and the coracoid process. So when you flex your bicep, you're actually bringing the radial tuberosity or the insertion closer to the origin. Well, this is important when we're talking about the actions of the rectus abdominis. If we bring our insertion closer to the origin, we're performing trunk flexion. And that is one of the major movements of the rectus abdominis. All right. And it's the main movement that I'm going to need you to know now. Okay. It's the main movement I'm going to need you to know now. We'll talk about pelvic tilts in kinesiology. But for now, what I need you to know about the rectus abdominis is that the origin is at the pubic symphysis, and its insertion is the xiphoid process. Its major action is trunk flexion. The innervation is the intercostal nerves. The innervation is the intercostal nerves. Now, in between each of these quote unquote six packs, these areas in white here, and each of these areas here is known as the linea alba. The two sides, let me just get rid of this for a second. right here is the linea alba. It's a piece of tissue that connects the two sides. So linea alba, all right? And that helps create that six-pack effect. So again, with the rectus abdominis, its origin, the pubic crest and the pubic symphysis. If you were to just say pubic symphysis, I'm perfectly fine with that. Its insertion is into the xiphoid process. Its main action is trunk flexion. Again, if you bring your xiphoid process closer to your pubic symphysis, you're flexing your trunk. And the innervation of rectus abdominis is the intercostal nerves. Okay? So that's the information that you're going to need to know for rectus abdominis. We're going to go more into it in kinesiology because it's really an important muscle. It's actually more of a movement muscle. It's not, again, it's not a core muscle. So when you're working the core, you've been thinking that you're working your abdominal muscle. Well, you're working an abdominal muscle, but it's this muscle you're actually working. The transverse abdominis is a core muscle. The transverse abdominis is a deep abdominal muscle. All right? It's very, very important to work this muscle. This is your core muscle. When you're talking working your core, we're talking about working deep muscles. Deep muscles. So what you need to know about the transverse abdominis, you will also see this muscle named in this way as a capital T, a small r, and a capital A. You might see it known as the TRA, transverse abdominis. Okay? You need to know its origin. Again, like the rectus abdominis, the TRA is actually low. All right? The iliac crest. This area here, oh, sorry. Let me go back to my pencil. The iliac crest here. The inguinal ligament, which is right here. All right? The ribs, these ribs down here, these are all part of the origin right here. It inserts into the linea alba of the rectus abdominis. It had, so that's what I need you to know about. I need you to know the origin and insertion, transverse abdominis and rectus abdominis have the same innervation. It's both from the intercostal nerves. I need you to know the important primary function of the transverse abdominis. And what it does, it compresses the abdominal area and it increases abdominal pressure. The transverse abdominis compresses the abdominal area, and by doing that, we're increasing intra-abdominal pressure. We will talk about that in kinesiology also, right? Because there's certain laws. Now, there's a law like Boyle's law that says that pressure is we'll go through it in kinesiology. I don't want to throw you a total curveball right now. But again, the important part that you need to know for transverse abdominis, deep core muscle, it helps with increasing intra-abdominal pressure. Again, it has a low origin and a higher up insertion. I'm starting to get the idea of this. Okay. The internal and external obliques. All right, these are muscles on the side of your trunk. And I'm not going to ask you where the origin and insertion is of these muscles. All right. What I'm going to want you to know are the actions of the muscle, because they are really, really important. And again, kind of like the SCM, they're a little confusing. They actually work together. Okay. They actually work together. So the external obliques look like you're going to put your hands in your pocket. So if you were to take your hand and rub and go along the side of your body, the external obliques has the direction like you're going to put your hands in your pocket. The internal obliques are in the opposite direction of the external obliques. So again, external obliques, like putting your hands in your pocket. Now, what you need to know, the internal and external obliques help with flexion, and they help with lateral trunk flexion. All right, to the same side. But that's not the confusing part. This is where things get confusing, is that we need both of these muscles in order to rotate our trunk. We need both of these muscles to rotate the trunk. And this is what I mean. So what I want you to do is I want you to rotate your trunk to the right side. So I want you to go like this. Rotate your trunk to the right. In order for you to rotate your trunk to the right, you're going to need the action of both the internal and external oblique. So if you rotate your trunk to the right, your internal oblique, you will use the right internal oblique to go to the right, and you will use your left external oblique to go to your right. So so you're going to use the right internal oblique and the left external oblique. So now that I've confused you, let's take it slow. So the internal oblique does rotation to the ipsilateral side. So ipsilateral, again, means the same side. So if we rotate to the right, the internal oblique rotates to the right. The right internal oblique will rotate to the right. The external oblique rotates the trunk to the contralateral side or to the opposite side. So in order to turn to the right, the left external oblique has to contract. So here is my right internal oblique. Here is my left external oblique. If I rotate my trunk to the right, my right internal oblique and my left external oblique contract to rotate my trunk to the right. Again, internal oblique rotates the trunk to the same side. So if I'm rotating to the right, my right internal oblique will contract. If I'm rotating to the right, it is my left external oblique that contracts, because the external oblique rotates to the contralateral side. It goes to the opposite side. Very confusing. I understand. So let's take it in a different way. If we want to turn to the left, so left trunk turn, left trunk rotation. Sorry, left trunk rotation. Sorry about that. Okay. So the internal oblique rotates to the same side. The external oblique rotates to the opposite side, or the contralateral side. So in order to go left, it would be the left internal oblique and the right external oblique that contract to do the movement. Thankfully, these are the only two possibilities. You can only go left, you can only go right. So if you were to write this down, if I do trunk rotation to the right, it's going to be my right internal oblique and my left external oblique. If I rotate my trunk to the left, it's going to be the left internal oblique going to the same side and the right external oblique going to the opposite side. Guys, that's why it's so important to get the terminology down, because not only will I be testing you on it, the national exam can use same side, contralateral, opposite, ipsilateral. They can use any of those terms, but it's these two terms that they'll use the most. So you've got to understand it. So again, the information that I need you to know for the internal and external obliques is, first of all, the external oblique looks like you're putting your hand in your pocket. It's at a diagonal, like you're putting your hand in your pocket. The internal oblique is the opposite direction. And you need to know that they both flex the trunk and they both laterally flex the trunk. But it's the rotation that is confusing. So again, if I rotate to the right internal oblique will contract and the left external oblique will contract to perform that movement of the trunk. You have got to know the rotation of the internal and the external obliques. Real important. That's the kind of question that they will give on the national exam. They're no joke. They will try to confuse you, and they will try to second guess you, make you second guess yourself. So when you're studying the muscles, understand the action of rotation with the internal and external obliques. Okay? Because they are opposite. Very important to understand. All right. So now let's go a little bit more into the upper chest area. So the next muscle that you will need to know, and you will need to know everything about this muscle, pectoralis major. This muscle is very weird in certain ways. The first weird thing is that it has multiple origins. All right. So the clavicle, the sternum, and the ribs are its origin. All right. As you can see, it's wide. If you look at it on yourself, it's literally coming from the middle of the clavicle, down the sternum, into ribs 1 through 6. Okay. So it's a large origin. Okay. And this is a big muscle. It goes across the chest, but it doesn't stay on the chest. It inserts in this area right here. It inserts onto the humerus. Now, I have down here the greater tubercle of the humerus. All right. I have no problem with that area, but the actual insertion point is in the bicipital groove. In the bicipital groove is where most of the pec major inserts into. Okay? So the greater tubercle and the bicipital groove would be your perfect answers for the insertion point. Now, this is important because if it's on the humerus, that means that it's going to have some kind of shoulder movement. All right. So it's not just at the chest. Okay. It's not just a chest movement. It is going to have major shoulder movements. The innervation is the medial and lateral pectoral nerve. All right. So pectoralis major, medial and lateral pectoral nerve. You will need to know all of the actions of the pec major. And it has multiple actions. What I want you to do first is I want you to picture the humerus here. Now, if we abduct, if we bring the humerus out to the side in this direction, we would actually be stretching the pec major. You're going to have to picture this three-dimensionally. This part of the muscle, if we abduct, is going to stretch or lengthen. It's going to lengthen. Remember, when a muscle contracts, it shortens. So after I abduct, in order for me to bring the arm back, it is the pectoralis major that helps adduct the shoulder. It's this muscle that brings the bone back to its original place. So shoulder adduction is a movement of pec major. Because it's on the anterior side, remember this, so this whole muscle is on the anterior side, and it attaches onto the humerus. When it pulls, remember, here's the origin over here, and here's the insertion. Well, if I bring the insertion closer to the origin, it's going to rotate the shoulder. The pectoralis major helps with medial rotation or internal rotation of the shoulder. So it helps adduct the shoulder. It helps internally rotate or medially rotate the shoulder. Pectoralis major is one of the 4 muscles that flexes the shoulder. Remember yesterday I spoke about A, B, C plus pec major. Well, these are the 4 muscles that perform shoulder flexion. Anterior delt, biceps brachii, and coracobrachialis. Here's the coracobrachialis right here. Coming off the coracoid process and attaches to the humerus. The biceps would be right here. Biceps would be right there. And anterior delt actually comes from here and attaches here on the humerus at the deltoid tuberosity. So all four of those muscles perform shoulder flexion, A, B, C, and pec major. So pec major has three major movements so far. It adducts the shoulder, bringing the shoulder back. It internally rotates the shoulder, or medial rotation, and it does shoulder flexion. It does a fourth movement, and it's a movement that we did not go over in the Zoom video, in the third Zoom video. It does something known as horizontal adduction. And what that is if we bring our arm up to 90 degrees with our elbow flexed, and we bring our arm inwards. So this is the horizontal plane right here. Remember, it cuts the body into an upper and lower half. Horizontal adduction, and remember, AD means going into the body. Pectoralis major does this motion, bringing the arm horizontal adduction. Horizontal abduction is the moving away in the horizontal plane. All right. So again, pectoralis major has four important movements. It flexes the shoulder. It adducts the shoulder. It internally or medially rotates the shoulder. And it horizontally adducts the shoulder. Pectoralis major has a large origin area, the clavicle, the sternum, and the ribs. And it inserts into the bicipital groove of the humerus near the greater tubercle. One other thing about pec major, when you look at your flashcards, because of its placement, it has certain muscle fibers on the lower half of the muscle in this area here that actually allow for extension of the shoulder. It is not a main movement that you will need to know. It is not a main mover. So the movements, again, that I need you to know for pec major: shoulder adduction, internal or medial rotation, shoulder flexion, and horizontal adduction. Those are the four movements of the pec major, and the innervation is the medial lateral pectoral nerve. Just deep to the pec major is the pec minor. Pec minor is a smaller muscle. It's deeper. I need you to know where it is located, okay? And I need you to know its main function. So the origin of pec minor, it's actually coming from ribs 3 through 5 right here. All right, pec minor comes from ribs 3 through 5, and it's a very small muscle. It goes from the ribs to the coracoid process on the scapula. So ribs 3, 4, and 5 is the origin. The coracoid process of the scapula is its insertion. It has the same innervation as pec major. So pec major and pec minor both have the medial lateral pectoral nerve. So both pecs have the same innervation. Now, the main function of the pec minor is to stabilize the scapula. The main function of the pectoralis minor is to stabilize the scapula. Because the scapula is not a true joint, it needs certain muscles and certain structures to maintain its stability. And pec minor is one of those muscles. The other important action that I do want you to know right now is that it protracts the scapula. So remember, protraction is the going forward of a structure. Well, pectoralis minor helps the scapula go forward. It works with the serratus anterior. The serratus anterior also does protraction. Okay. You will also in kinesiology find out that pectoralis minor works with other muscles in order to perform another motion. We'll talk about that other motion in kinesiology, and we'll talk about what those other muscles creates something known as a force couple and what they involve. So for pec minor, you need to know the origin as ribs 3, 4, and 5. It inserts into the coracoid process of the scapula. Remember, it's that finger-looking projection on the anterior portion. Remember, pec minor is on the anterior portion. You can see it because you could see this gentleman's face, and you could see the sternum there with the manubrium, the body, and the xiphoid process. It's innervated by the medial lateral pectoral nerve, same nerve as the pec major. Its main two functions is to stabilize the scapula and to protract the scapula. Protract to bring forward, retract to bring back. Okay, so pectoralis minor is a protractor of the scapula. That. Okay, so the next set of muscles we're going to look at are some of the muscles of the posterior trunk. All right, so these muscles on the posterior trunk help extend, rotate, and laterally flex the vertebral column. And these muscles also help with upper limb movements. So we're talking about mostly shoulder movements. So these back muscles, again, help with moving the vertebral column, and they help with moving the upper limb. So the first muscle that you're going to need to know is the levator scapulae or levator scapula. You need to know everything about this muscle. All right. You need to know its origin, its insertion, innervation, and the actions. Okay. So first things first, the origin of this muscle is, so now we're looking at the back. So now we're looking at muscles that have origin and insertions on the vertebra themselves. All right, so we got to think about where it's coming from. So levator comes from right up here, the C1 through C4 transverse processes. Remember, those transverse processes of the cervical vertebra are the only ones also that have transverse foramen in them, because those nerves and blood vessels go up into the brain. So they need that area, they need the stability of those transverse foramen. So the origin of levator scapula is the transverse processes of C1 through C4. It inserts into the medial border of the scapula from the superior spine, from the superior angle to the spine of the scapula. And this is why it's so important to know the landmarks of these bones. Okay, you got to know that the transverse processes, that the levator comes off of those transverse processes and comes down to the scapula, but it doesn't attach to the whole scapula. It is on the medial border. Remember, the medial border of the scapula is close to the vertebra. The superior angle is up here. Here's the superior angle. Here's the spine of the scapula right here. And here's the inferior angle. So you've got to know these landmarks because these muscles go to specific places. Because when they go to these specific places, they're only allowed to do so much actions. Okay? So transverse processes of C1 through C4 to the medial border of the scapula from the superior angle to the spine of the scapula. It's innervated by the dorsal scapular nerve. The dorsal scapular nerve. The action that I need you to know now is that it elevates the scapula. So again, here's its origin, and here's its insertion. Now, what I need you to do is I need you to picture, it's hard, you got to start thinking three-dimensionally, guys. This is one of the things that it took me a little while to get, but you really have to think in a three-dimensional way. How is this muscle going to move? Well, the insertion is going to move towards the origin. Well, the insertion is on the scapula. So it's going to move the scapula upwards. So one of the actions that it does is scapula elevation. It does scapula elevation. Another motion that it does is that it laterally flexes the head. It can actually perform this motion, bringing the head down this way. Now, I just said that the insertion always goes towards the origin. But there are times when the origin can go towards the insertion. You will learn about that when we start talking about open and closed chain movements. So the two actions that I want you to know right now for levator scapula is that it elevates the scapula, it lifts the scapula up, and it can help with lateral flexion of the head. Remember, we had a couple of muscles earlier that did lateral flexion. Remember, sternocleidomastoid did lateral flexion to the same side, to the ipsilateral side, and so did scalenes. All right, so levator scapula is another muscle that helps with lateral flexion. And another action that it does, it helps with head extension. Again, thinking, if we can actually bring the occiput down this way with this muscle when they work together. So remember, you're going to have another muscle on this side. When they work together, those muscles will actually bring the head backwards in extension. And remember, we talked about Splenius capitis and Splenius cervicis being head extensors. So these are some of the ways that you can start to remember these things that I actually went over about an hour and a half ago. and kind of bring those things in. And the more you talk it through, the more you will understand these muscles. This is not something you get right off the bat. It takes work. That's why we want you to start studying them now. You have you have 5.5 weeks till the class starts. Now's the time. So again, levator scapula. Its origin, transverse process C1 through C4, inserts into the medial border of the scapula, the portion from the superior angle to the spine of the scapula. Its actions, its main action is scapular elevation. It assists with lateral flexion of the head and head extension. And it's a dorsal scapular nerve. So those are the things that I need you to know for the levator scapula muscle. I think we're going to end today at the trapezius because the trapezius is going to take a little bit. Like I said, the next couple of days, we're going to go through all of these muscles. So it's not going to be a one-day affair with these muscles. The trapezius, on your practical, you're just going to have to show me that you know what the trapezius looks like. Remember, it's this diamond-like muscle, and it goes all the way down here on both sides. So for your practical, you're going to have to identify this muscle. For life as a physical therapist assistant, you're going to have to know all the parts of the trapezius. This is a 3-part muscle. We have an upper trapezius. Here is the upper trapezius right here. We have a middle trapezius, and we have the lower trapezius. You're going to have to know each of their origins, each of their insertions, and each of their actions. You will be thankful that the only innervation for this muscle is the accessory nerve. Remember, cranial nerve number 11. Okay, cranial nerve number 11. The accessory nerve innervates all 3 parts of the trapezius. All right, let's go into it. So we're going to start with the upper trap. The upper trap, its origin is the external occipital protuberance. It is on the occiput of the head, that bony projection. Again, that's why we need you to know the bony landmarks. Okay? For your practical, you're just going to have to tell me what bone this is. It's the occiput. But you need to know the landmarks of these bones. And the reason you need to know the landmarks is because these muscles are on them. Right? The muscles are on them. So the upper trapezius starts at the external occipital protuberance. Again, the ligamentum nuchae also, remember that's that ligament. I'm not worried about that. External occipital protuberance, and it inserts onto the lateral third of the clavicle. Upper trap, origin, external occipital protuberance, it inserts into the lateral third of the clavicle. You're going to see that there's a sequencing to this, okay? There's an actual sequence, okay? So if you can get the sequence down, you will be okay, okay? So upper trap, external occipital protuberance to the clavicle. The upper trap helps elevate the scapula. It helps elevate the scapula and does some neck extension. Okay, each of these muscles do separate actions. Okay, so upper trap goes from the external occipital protuberance to the lateral third of the clavicle. Its action is that it elevates the scapula, just like Levator's scapula, and it helps extend the neck and the head. The middle trap basically is this area here. Comes from this area to this area. Middle trap goes from C7 to T5. All right. It comes from the spinous processes of C7 to T5. It inserts onto the acromion process of the scapula. So upper trap inserts on the clavicle, middle trap inserts on the acromion process. Its action is retraction of the scapula. So the middle trap brings the scapula and brings both scapulas backwards. Remember, we got protraction, and I said earlier that pec minor is a protractor. Well, the middle trapezius is a retractor. The two main protractors of the scapula are pec minor and the serratus. The two major retractors is the middle trapezius and the rhomboids. Remember, the rhomboids is that muscle that goes at a diagonal right here, that goes from the vertebral column to the scapula, both in that same area, that middle area. We'll go over the rhomboids tomorrow, probably. So again, upper trap from the occiput to the clavicle, middle trap, the C7, T5 area to the acromion process. The lower trap goes from the T6, T12 area, so this area here, and it inserts onto the spine of the scapula up here. Okay? So lower trap goes from C6 to T12 is the origin, and it inserts onto the spine of the scapula. So the insertion points of the trapezius: upper trap, clavicle; middle trap, acromion; lower trap, spine of scapula. The action of the lower trap is the opposite of the upper trap. The upper trap elevated the scapula. The lower trap depresses it or brings it down. Okay? Upper trap brings it scapula up. Lower trap brings the scapula down. The middle trap brings it backwards or retracts. The origins of each: upper trap is on the head, is on the occiput. The middle trap goes from C7 to T5, goes from the bottom of the cervical to mid-thoracic, and the origin of the lower trap goes the rest of the way all thoracic. All right, T6 to T12. No lumbar area here. Okay, no lumbar. Okay, so you've got to know, A, what the trapezius looks like for your practical, but on your quizzes and on your final exam, you're going to have to know the three parts of the trapezius: upper trap, origin, external occipital protuberance, it inserts into the clavicle. The middle trap, its origin is C7 to T5. It inserts into the acromion process. The lower trap, its origin is T6 through T12. It inserts into the spine of the scapula. They each have different actions. Upper trap, its main action is scapular elevation. The lower trap, its main action is scapular depression. The middle trap, its main action is scapular retraction. And the trapezius as a whole is innervated by cranial nerve number 11, which is the accessory nerve. Okay. I think we'll stop here today. All right, we'll stop at trapezius. So tomorrow we will start at the rhomboids. Perfect. Okay, so tomorrow we'll start at the rhomboids. Bridget, are you the only one here? Can't tell. Here. Let me just get out of the stop share. So Bridget, looks like you're the only one here today. Okay. Do you have any questions? A lot of information.
Yeah, it is.
Here's the thing. Hearing it the first time through the next couple of days, a good thing. Then getting some kind of book to go through them, so you're reading it for the first time and hearing it will help you. If you can get the trail guide as soon as you can, it's going to help you a lot. All right, the trail guide book. If you can get the flashcards, good. Any kind of flashcards. If you can get an app, all right, there are so many apps out there now. All right, or even just go to Wikipedia and type the muscle in, and it will show a picture of it. All right, and it will give you all that information: the origin, the insertion, the action, the innervations. But remember, the information that I'm going to send to you on the lecture material, I'm going to send that today. That's probably the better to use, because every piece of information that you'll see has different information. I'm trying to guide you in what you need to know. Okay? So gather up questions. If you're here tomorrow, if you got any questions on the stuff that we went over, ask. If it's later on today, and let's say you're looking at it and you got a question, please feel free to email me. I check my emails every 2 hours and right before I go to sleep. This way I try to get back to you guys in a timely manner. Okay? All right. Tomorrow we will start at the rhomboids. Everybody have a good evening, and I will send out that information right now. All right. Have a good week. Have a good one, and I will see you guys tomorrow. Bye.